Hello, and welcome to the November Mission Impact Volunteer Call on Early Detection. Today's speakers are Anastasia Albanese O'Neill, AVP of Community Screening and Clinical Trial Education, Esther Latris, Vice President of Research, and Erin Turner Pfeiffer, Senior Director, Health Policy.
Hello, everyone. My name is Esther Ladres. My title is VP of Research, and I look forward to providing you with an update on screening and early detection. So the next slide, Brian, is our vision for the program, which is a future where T1D is identified years before individuals need insulin, integrated into healthcare systems globally, and accompanied by effective preventing therapies. What does it mean? So basically what it means is we're trying to avoid insulin dependence at early stages. This is obviously the main goal of the early detection, and it aligns very well with our mission, which is a world without type 1 diabetes, and involves cures at early stages. So these are early stages before the clinical diagnosis, where beta cells or cells that produce insulin can be safe and can prevent insulin dependence. So the next slide is the how type 1 diabetes progresses and the stages. So I'm going to start with stage 3, right in the middle, where it says clinical, and that's where the time of diagnosis. This is where a lot of the um, diagnosis is through diabetic ketoacidosis, which is obviously a really devastating way of identifying clinical diagnosis. So if we start from stage 3, this is a stage where there are not enough functional beta cells to prevent insulin dependence. We're making a huge effort here and focus on developing therapies at that stage to maintain C-peptide. Even though may not be enough to prevent insulin dependence, we believe that maintaining C-peptide and islet function at that stage, at the time of diagnosis, can prevent complications and there's a lot of studies showing that maintaining even low levels of C-peptide is beneficial. But we're talking about stage 1 and stage 2, and these are the stages that are not, there's no clinical manifestation. So the only way to identify these early stages is through screening. And we'll talk about the screening with autoantibodies. And autoantibodies are basically immune biomarkers that allowed to identify the presence of autoimmunity. So in stage 1, there's the presence of these autoantibodies. It means that the immune system has already activated they don't recognize beta cells, and there's this process of immunity. In stage 2, there is a more advanced stage. That's where the immune system has already targeted some of the beta cells, and there's inability sometimes to maintain glucose levels. That require a test. There's no need for insulin, but in order to identify what we call dysglycemia, it requires a test. So in stage 2 is presence of antibodies and what we call starting dysglycemia, but there's no insulin dependence. And stage 4, I think it's long-standing, or where we're focusing on cell therapies and treatment where there's full lack of insulin and we need to replace it. The next one, I'm gonna just show the benefits of screening. As I mentioned, reduce the risk for diabetic ketoacidosis at diagnosis. That's detecting type 1 diabetes by the presence of diabetic ketoacidosis in emergency room has a lot of effects, even long term. So there's a lot of studies and a lot of data that shows that preventing TKA diagnosis is important, and it's key. Identifying people who may benefit from early intervention clinical trials. So as I said, it's the stage 1 and stage 2 It's not clinically manifested, so we need to identify through what we call biomarkers and glycemic markers. Give individuals and families time to prepare, to understand what the options are in terms of the clinical trials. Obviously, there is an FDA-approved therapy to delay clinical diagnosis of T1D and the need of insulin. So there's great benefits of screening and early detection. The next slide. So Breakthrough T1Ds focus on driving early detection forward with three approaches. And why do we need three approaches? The first one is research. We need to provide the data. We need to provide the evidence for the feasibility and acceptability of early detection and how important it is monitoring the early stages of type 1 in the clinical setting. So it's providing all the evidence that then the regulatory and health policy can use to make stronger case to get affordable access to type 1 early detection, to get regulatory approval from disease modifying therapies and build health policy plans in order to get reimbursed or get these systems get adopted by different health system. And then the last one is clinical adoption, is how do we educate healthcare providers that screening is important, that there's no need to wait for clinical diagnosis of type 1 because it may be too late. And if there are ways to prevent, I think it's the most important to provide education, clinical guidelines, and also implementation science. What it means is just creating the infrastructure, creating the research tools that are required or clinical tools to require screening in a very efficacious way. So the next slide is when we talk about the research goal and building evidence for the feasibility and acceptability of early detection and monitoring in the clinical setting. What does it mean? So I tried to, I think 3 years ago, I'm sorry, 1 year ago, I provided an update on where we were in building this evidence. So I'm just going to focus on three main activities that we focusing and advancing. And the first one, it's in the next slide, Ryan, thank you. The first one is implementing early detection recommendations. And how do we move all the data that we have to the next stage to recommend implementation of screening? We have to build all the data, and the strongest evidence is in children with family history. So we know that having family history of type 1 increases the risk of developing type 1 up to 15-fold. This is where at that time, JDRF started building the screening programs. We have a lot of data. We have progression data. We have, I think, very strong package. And I think in the later sections, my colleagues Aaron and Anastasia will talk about it, how to move all this data and how it's been moved to get some implementation efforts. But we also know that there is a robust evidence supporting early detection of type 1 in the general pediatric population. So 85% of diagnosis happens in people with no family members. So we're trying to build, again, feasible, acceptable, and cost-effective models that can support the benefits of screening in the general population. So this is what we mean by implementing early detection recommendations. And this is the main effort that we're working with Anastasia and Aaron. So the next one, I put two more, this is the antibody screening landscape. So as you know, we are international. There are so many programs that have contributed to our understanding of the benefits of screening. So this is, you can when you see when you get the presentation, you can look into more details, but it's mostly across the world. And we have separated the first degree relatives with the general pediatric population screen. The next slide. So the next two focus areas that I'm going to briefly mention is the adult onset and genetics. And why are we focusing on the adult onset? It's nearly half of newly diagnosed cases of type 1 are adult onset, but we're very limited in our understanding, whether genetics, immunology, and some metabolic differences. Some of the investigators and clinicians refer to different endotypes, the pediatric and adult. I don't think it's a very well accepted term, but there are differences. There are differences in how do they present in terms of what I mentioned before, in terms of autoantibodies. It's not so clear that in adult there's the same presentation of multiple antibodies and the dysglycemia. So there seems to be a different progression, and we need to study that. Um, and I'll briefly mention genetics. And what I mean by genetics is that there are risks alleles in the population that can predispose to type 1 diabetes. So it doesn't mean that being in the high risk of the high risk predisposition means that someone is going to get type 1 diabetes. That's not what it means. There's actually a very small percentage of people in the high risk population that will go into diabetes, but the our thinking around using genetics is that maybe it narrows the population where they need to maybe get an autoantibody test, or maybe they need to monitor, or maybe they need to um, follow or monitor a little bit. Obviously, we need to balance maybe is there anxiety? Maybe we need to communicate better on what it means to be in the high genetic risk. So we have studies. We have in I think the next slide. It shows. Oh no, sorry. I'm going back to the adult onset. So I'll just finish with the adult onset. There's one screening program in the UK, TIDRA, that the age is 18 to 70, and this is for autoantibodies. As I mentioned before, most of the screening are pediatric. So this is one of the studies that I think it's quite of important to show the presence of autoantibodies in adults. Um, but again, as I mentioned, autoantibody positivity, we already know that adults present with much, much less autoantibody positivity, but we still need to understand. We're also addressing the fact that 40% of the adult onset type 1 are being misdiagnosed at onset. How can we address this issue? And I mentioned that last year we have two very exciting projects that what they do is take electronic medical records. So all the information of many individuals that they've gone to the doctor and they've been diagnosed with type 2. And then 2 years later or 3 years later have been finally assigned to type 1. So using and building on all these amount of data, we believe that we can create algorithms with all this information, the clinical data, that can give us or give the clinicians better tools to diagnose type 1 from the beginning when somebody shows in the clinic. And that is important because if there is an autoantibody and there are therapies that are specifically designed for type 1, they should benefit from these therapies. And then I think there's also a component genetics here in the adults, but I think I'll address it better in the next slide, which shows very nice distribution of the landscape on genetic risk score assessment. And this genetic risk score is based on these HLA haplotypes. These are these kind of immune police that we all have in our cells, that they show what belongs to us and what doesn't. But there are sometimes some of these HLAs that they've been related to a predisposition to type 1 diabetes. But again, we need a lot of data, and I think we are studying if this genetics or GRS score, genetic risk score, can help us maybe identify the people that again may benefit from an autoantibody screen, which is the absolute necessary biomarker that will indicate progression into type 1. So the next slide summarizes what we're doing on improving the detection and monitoring. As you know, when we identify gaps, we define and we put what's called calls for proposals. That's how we reach out to the scientific community. So prediction is very important in the early stages. As I mentioned, going back to the dysglycemia, can we use automated devices like CGM, for example, that are very sensitive at detecting changes in glucose response and glucose variability in the early stages? So that's something that we're looking into, and we put one of these calls. So we are waiting for proposals to better help us identify who will advance faster, who advances maybe slower, who would benefit from these therapies. So we're looking forward to these projects. And again, it's a we need to harmonize and standardize to better predict progression, right? So with guidelines and monitoring guidelines, if we include genetics in the future, how we include genetics, if adult screening may be a little different than pediatric, also we need to standardize. So I think we have a lot of experience on the monitoring and the guidelines from, again, you'll hear later, but that's harmonization, I think, and standardization is key. And this community, I have to say, that all the researchers and clinicians in the screening and early detection for type 1 are all very, very very engaged in building this monitoring guidelines and for clinical detection. So I think it's my next slide is the last one. So in summary, early detection and monitoring in early stage provides individuals and families time to prepare, interventions, accelerate clinical trial recruitment. That's something we did not talk about, but we need early stage or individuals that we can recruit into clinical trials. There are a lot of clinical trials, I have to say. Last year, you heard that disease-modifying therapies talk. Very exciting time for immunotherapies in the stage 3, but we think we may move them into early detection, may be beneficial in early detection. I mean, sorry, in early stages of type 1. So I think it's a good time to accelerate these clinical trials. And the goal and the vision, as I mentioned, is to delay insulin dependence. So I think that's my last slide. Thank you so much.
Hi, I'm Anastasia Albanese O'Neill, and it is my turn to talk about how breakthrough T1D is approaching early detection from the clinical perspective. So, you've heard it used to be called T1 Detect, now it's called early detection, and we have three strategies we use to think about how we can expand equitable access to screening, monitoring, and then clinical adoption of these really groundbreaking therapies that our research is bringing forward. So the first area we focus is on increasing the capacity of healthcare professionals to support these emerging therapies in type 1 diabetes. And this involves thinking about the clinical guidelines, making sure healthcare professionals have, sort of very, very up-to-date knowledge, and it's changing very quickly. And then we're working actually in the clinical setting to thinking about how we can expand access and really increase healthcare professional competencies in these new areas of diabetes care. And the second strategy is reducing disparities. We want to make sure that when these innovations come forward, that everyone has access, and that really takes place in our clinical pilot program, which I'll talk more about in a moment. And then finally, we want to activate the type 1 diabetes community. We need everybody to understand what their options are and be able to have an informed conversation with their care team and also educate others. And we're doing that sort of at the very high level through our digital communication strategy in partnership with Marcom and community engagement. And then also we need all of you to be spokespeople for this program. And so I'll say more about both of those things in a moment. Let's talk about clinical guidance. You've probably heard that we convened a couple of years ago a group of international experts to write down how to follow up with people in clinic who are autoantibody positive, who are in those earliest stages of type 1 diabetes. Why does that matter? Well, we have some choices, especially here in the United States. What we know is if you've screened and you are autoantibody positive, we can reduce DKA at diagnosis. We can also introduce you to research opportunities to help us learn how to prevent type 1 diabetes and delay it. And then also we have an approved therapy in the United States. But if your healthcare team can't see you, and if they don't have guidance on how to follow up and how often, then often that care doesn't happen. We saw this as a huge gap in clinical care and convened this international group of experts. What is so exciting is without any funding, they leaned in and wrote a really important paper that was published in the top two diabetes journals here in the United States, Diabetes Care, and in Europe, Diabetologia. And since June 24th, folks, this paper, what seems like a stodgy clinical guidance document, has been accessed over 20,000 times, and it's the #1 paper in the leading diabetes journal in Europe. So why does this matter? It matters because now clinicians all around the world have a consensus guidance document that they can follow to care for people in early stage type 1 diabetes that helps us take care of people in the earliest stages of type 1 diabetes. And we know now that there's a diagnosis code for this. And so they can see them in the electronic health record, and they have the guidelines to provide evidence-based care. So this is a really important effort, and we're super proud of being involved in it. What's also exciting is if you interact with healthcare professionals, we have created a front and back document that summarizes this material into 2 pages. There's a QR code. Look on your left. There's a QR code that takes them to the actual document, which is open access. But if you're a physician or a nurse practitioner or a diabetes care and education specialist, you can quickly read this summary. In addition, for families who have a child in early stage type 1 diabetes or adults who are autoantibody positive but don't yet require insulin, we've created a front and back page document that will tell you what you should be thinking about and what you can expect in terms of your care if you are living with early stage type 1 diabetes. So check those out. They're in Brand Hub. That's for staff and volunteers. These will be available online. The world of type 1 diabetes care has changed. I had to pause for a moment. We have a new paradigm in type 1 diabetes care, and I think there's no better way to describe it than looking at the chapter on the prevention and delay of diabetes and the standards of care, which we follow clinically that guides us in the care we provide. This year, folks, in January of 2024, the chapter title changed. It used to be called the prevention or delay of type 2 diabetes. Now it is called the prevention or delay of diabetes. Why? Because we can now, for the first time, with teplizumab, an FDA-approved therapy, delay the requirement for insulin in type 1 diabetes on average for 2 years and possibly longer in some individuals. But this creates significant changes in our clinical activities. And what we know is most people who are out there working in diabetes care, whatever their training, whether they're a social worker or a psychologist, a dietitian, they probably didn't learn about this during their formal education in medical school or in nursing school. So forthcoming in January, you've got to wait for it, but we will have a new healthcare professional landing page where some of those documents I just showed you and a lot more will live on the Breakthrough T1D website. And I want to thank there are so many people to thank. I can't name them, but in particular, the team and Amanda Gottlieb for really pushing this through, and of course, Nikki Bodner for her fabulous design efforts. One of the really important things you're going to see on this site is accredited healthcare professional education by this list of faculty. These are key opinion leaders in type 1 diabetes from around the country who have contracted with us to provide at no cost to the healthcare professionals accredited education that they can use to get up to speed on the diagnosis and classification of diabetes, so we don't misdiagnose adults, on how you can get screened if you come back with positive autoantibodies, how you should receive care or how you should provide care in the clinical setting. This will be available January 2025. We're rolling some of it out now with a soft launch, but come back to the webpage in January. A lot to see there and a lot for you to share out in the community. Pilot clinics. This is number 3 in our tactics that we're using to really accelerate the adoption of these new therapies and opportunities in the clinical paradigm. We have around the country 10 contractual partnerships. We have 3 pending, and we are looking at how do we implement screening and monitoring in the actual clinical world? How do we do that? And we're trying to demonstrate that it can be done, that healthcare professionals like it and can do it, and so do their patients, the people they see in clinic, and that it works, that we can identify people early and then connect them to clinical trials, connect them to approved therapies, and make sure that we prevent DKA at diagnosis. So we're doing all kinds of work and we are learning a lot, and these partners are working on getting this evidence into the literature, into the academic literature, so that it can be eventually included in the guidelines. Guidelines rely on evidence, so these clinical sites are helping us put evidence behind early detection and follow-up care. So what are we learning? Well, we're learning we can improve access and diversity in people who participate in screening and follow-up care. On your left, you see University Hospital. They've screened over 1,000 people, approaching 1,500. And what's exciting about this site, it's a community-based program. We're seeing a lot of diverse participation in this, which isn't typical in screening program. So over 70% of the people who've participated at this site identify as non-Hispanic Black, about 24% is Hispanic, and less than 1% is non-Hispanic white. So lots of diversity and participation, and creating a lot of trust in this process, in this particular setting. We're also learning about how do we do this in clinical care? What kind of visit do we schedule? And all kinds of really not very exciting stuff about clinical processes, but very, very important. And one thing I'll note, we've got a quote down at the bottom at the slide that says, "I didn't know children could get diabetes." We talk a lot at Breakthrough T1D, and we indeed changed our name because a lot of people didn't know that adults could get type 1 diabetes. But what we're hearing in this clinic, in many communities, they're still thinking about communities in particular impacted by type 2 diabetes, which used to be called adult onset. They aren't thinking about kids getting diabetes. So we're bringing screening to communities that don't think again about children getting diabetes, which is very unusual here at Breakthrough T1D. But in our broader community, that is some knowledge that we need to share. I will also say this next clinic in the middle is a very rural clinic in Idaho, a town of 900. They've screened over 50 people, a huge percentage of their town, but they're teaching us on how people learn about screening. Often it's the provider who talks about it, but they're also doing work in social media, and people are coming in to get screened because they're hearing about it in social media. I know a lot of us live on social media nowadays, for better or for worse, but this is teaching us how to communicate about screening and how to get the word out. And then finally, the third example I'll share with you is a clinic in Indiana. It's in Amish country. They've screened almost 100 people in just the past 6 to 7 months. And this community in particular has a really high incidence and prevalence of type 1 diabetes. So they've already identified a child in stage 2 type 1 diabetes, and that child has received a teplizumab infusion. So talk about feasibility, and then people accepting this and wanting to do it, and then efficacy, getting somebody connected to a therapy. So really exciting work out of our partners in Indiana. What I will also say is what this clinic is learning is that some of the adults in the clinic who were diagnosed as adults with type 2 diabetes, now that the clinic is learning a lot about autoantibody screening and testing, not only in early type 1, but at a stage 3 type 1 diabetes diagnosis, what they're finding is some of those adults actually have type 1, and now they're connecting them to appropriate care. So lots of learnings in our pilot clinics, more to come. Connect with our team if you want to learn more, and they're working on publishing these findings. The other thing that's really exciting is that all of these clinics are building out resources that can be shared in similarly situated clinics. So our clinic in New Jersey is a large urban hospital that provides care to tens of thousands of people. Their materials can be shared with similarly situated care facilities. But our small federally qualified health center in Idaho has a different approach. Those can be shared with other federally qualified health centers or FQHCs, so people don't have to reinvent the wheel. And our materials are in Spanish, and we're bringing forward materials also in Creole and in the future Arabic, because those are the languages being spoken in these clinical settings. So you've got an email there where if you've got a clinic in your community that would be interested in some of these materials, please contact us, and they will live on our new HCP facing page in January. And then you've heard on the town hall about our efforts to educate very broadly about early detection. We need to activate the type 1 diabetes community and the 90% of people who will be diagnosed with type 1 who have no connection to type 1 diabetes, no family history. We need to share the word about the importance of early detection. And so we're doing that through a program called Detect So You Can Decide. I know you saw this on the town hall, so you can watch that information for those of you who are staff, but for volunteers, what I want to share is that you are going to start seeing on social media a lot of storytelling from people who've participated in screening and early detection, and from healthcare professionals who are providing this care and why it's so important to our mission. So more to come there. It's already on social media, but continue to look for it, and please share widely. And right now, all of you in anywhere in the US can talk about the screening pathways on this document, which is available at breakthrough T1D/early detection. This talks about literally how every person in the United States could be screened. TrialNet, as many of you know, is for family members. Ask right now is actually providing screening for anyone, children and adults ages 1 to 99. That's kind of the second QR code on your left. And then if you'd like to get screened, or someone in your community would like to get screened in their doctor's office, on the right where you see those three QR codes, that will provide information for their clinician to order screening in the clinical setting. And we've got some additional information down below, and also teaching about the symptoms for anybody who comes back with positive results. So share this document widely, breakthrough T1D/early detection. Finally, we need all of you to be our spokespeople around screening. Our team spent the past 2 years traveling all over the country. We spoke to over 6,000 people about screening, and a bunch more about other things like technology and actually adjunctive therapies and more. But what we know now is you are our most powerful spokespeople. We have a slide deck that you can use. It's got talking points that you can use at meetings where you're asked to talk about early detection and clinical trials. But if you don't feel comfortable doing that, we have engaged 6 amazing volunteers who have been trained up on this and have their own individual stories to tell about participation in early detection and in clinical trials. And they can we will fly them there. We've got money in the budget to fly them to your community, to talk at your community summits, to speak virtually. We don't have to fly them anywhere to do that, or to your youth leadership councils, or wherever you would like them to be. So get in touch with us, request a speaker, or ask us about using that slide deck. There are so many exciting things happening. We want you to be a part of this. Please reach out to me or our team. And that is what I've got to share with you today.
Hi, my name is Aaron Turner Pfeiffer. I'm the Senior Director of Health Policy here at Breakthrough T1D. I'm part of our advocacy team. And you've already heard from Esther and Anastasia about the work that they're doing to expand T1D early detection. And I'm here to talk to you today about how we can utilize the levers around health policy to advance our goals of T1D screening for everyone. So if you are reviewing this the day it is sent, you are one of the first folks to be aware of this campaign that we're announcing. I'm actually located here in Denver where there's no snow, so I feel a little cheated by that. But here in Denver to announce this initiative at a symposium the Barbara Davis Center is hosting around T1D early detection. So excited to get this kicked off the ground, excited to share it with you today. And so just want to reiterate what you've already heard. around our vision to expand T1D early detection to everyone, general population. And we're doing this cross-functionally here at Breakthrough T1D. So I work as part of our advocacy team. We're working closely with Anastasia and Esther and teams across the organization to ensure that throughout the U.S. delivery system, everyone has an opportunity to get screened. We know that, as you've already heard, improves the lives of those who are at risk of developing type 1 and lets them get on a path to better care and potential interventions. And so on the policy side, you've already heard a great deal about closing research gaps, closing clinical implementation gaps. On the policy side, what we're focused on is taking the data we have today and ensuring that the delivery system is responding to the data we have today. We feel obviously very strongly that we have good data, good information to change the current delivery system for the better. And so on the policy side, we're focused on doing that. A couple of ways we're focused on that is that better insurance coverage, making sure the infrastructure, things like ICD-10 codes are in place for early detection. And then what we're going to talk about today is the United States Preventative Services Task Force, lovingly referred to as USPSTF, what I will call the task force for today. So let's talk a little about our campaign. To start, let's do background on USPSTF for the task force. So what it is and what is their mandate? The task force is a government-sanctioned body that is comprised of 16 experts, typically physicians that are appointed by the Secretary of Health and Human Services, and they give recommendations on preventative services. And that's their writ. It is one of the few instances in the U.S. delivery system where there's an independent body assessing and making medical recommendations that has some impact on the course of care folks receive. So what's the impact that they can have? Well, they do give out a grade. So for folks who miss getting graded, we're going to go through this process and get a grade. They do it on an A, B, C, D grading scale. No F. I guess that's an added bonus. But A and B are those what we call a positive recommendation. Grade A or grade B preventative services are required to be covered at no cost by all U.S.-based health plans, both commercial, Medicare, and Medicaid. Again, these are free for patients. And the data shows for those services that get a positive recommendation from the task force, we do see utilization for those services increase. Now, you don't want to grade C or grade D. Those are places where we don't want to be. But a grade I simply means that the task force believes there might be some promising data in this space, but not yet enough to deliver a recommendation. So the good news is if you get a grade I, you are on the agenda. You have an opportunity to generate new data to submit evidence and potentially go for that grade A or grade B. So obviously we will be shooting for a grade A or grade B. I've already mentioned the impact. I just want to highlight here, the impact aligns directly with our vision that you've heard about expanding T1D screening for everyone globally and also here directly in the U.S. This is a U.S.-based effort. And so, a positive recommendation directly supports, elevated knowledge, both on the payer side, but also on the clinical side, is a step closer to routine screening for everyone. And obviously the impact of the law around a positive recommendation means that, we've closed that potential gap that might exist on the insurance side. So like many things, if you're familiar with Breakthrough T1D and how we go about things, you won't be surprised to know that we did a pretty comprehensive assessment of the data we have today around T1D early detection and the USPSTF requirements. We wanted to make sure if we were going to commit resources to this effort, it was something that we had an opportunity to be successful in. And so we did worked with some outside experts in the USPSTF process, compared the data that exists today against the model that the USPSTF evaluates evidence, and came back with very, very promising feedback. And so the recommendation from our experts was that we should move forward with this, particularly given the breadth and depth of data around kids with a family history. And so, we'll be putting together an application to nominate this for review by the task force based off of this positive feedback we received from the experts. And so we're not going to do this alone. We know through experience of many things that to change the delivery system here in the U.S. in a meaningful way requires a community effort. And so we're going to be leading a community effort to get a USPSTF positive recommendation. This is going to include other patient advocacy groups, other clinical groups, key opinion leaders in this space who many of whom have been doing decades of research on T1D early detection. And our commitment as we lead this effort is to continue our research funding, continue to invest in efforts to expand clinical adoption, and then continue our work both on Capitol Hill and with policymakers at the federal level in places like the Department of Health and Human Services and the Centers for Medicare and Medicaid Services to raise awareness about the impact and importance of T1D early screening. And so through this process, we will get feedback from USPSTF. We might have opportunities and gaps that they make us aware of additional data that needs to be generated. And our commitment here at Breakthrough T1D is to fund any of those gaps that are identified. So this is just a quick overview of our new campaign that we're launching. We are optimistic in this work that we're going to be successful, and we look forward to one step closer to a day where everyone has access to T1D screening. Thanks. Have a great day.